Okay, so we're going to be looking at some anatomy and physiology. The study of anatomy and physiology of the human body is a very fascinating thing for some people, and other people find it very, very hard to understand. But as a fitness instructor, it's really important to understand how the structure and the function of the human body works, especially in relationship to exercise. I'm going to have a look at our first slide today, which is talking about terminology. So anatomy is the study of the structure of organisms, and physiology is the study of the function of organisms. Okay, so that is a quite important statement and question, and one that you need to understand the difference between the two. The word skeleton is Greek for dried up body, which I find quite funny. I always think of dried up as being like prune-like, but yeah, so it's a Greek word for dried up body. The skeleton and the functions of the skeleton are different, obviously different functions that the skeleton does. So one of the things is it supports, so it helps us stand up, it helps us keep upright, it helps us keep our posture. If we didn't have a skeleton, we just had, well, your muscles would not stand up, so it's a bit like having a coat hanger and hanging all your muscles off of your coat hanger. It's also protection for our vital organs, so especially in the torso region where our heart, lungs, liver and all of those vital organs are held within the rib cage as protection. So support obviously leads to movement, and as we look at protection for our vital organs, also the skeleton stores blood cell formation, helps with blood cell formation and storage for fat and for minerals. So the skeletal system, we have joints and we have bones. We have long bones, flat bones, short bones, irregular bones. We also have the axial skeleton and the appendicular skeleton. And the skeleton system is where our red blood cells are produced in our bones. So very, very important function, as well as our musculoskeletal system joined together. Very, very important. If we look at the types of bones that we have in our skeletal system, we have compact and dense, hard, and this forms a protective exterior portion of our bones. So we're talking about the outside of the bone. And inside the bone, it is spongy, or what we call cancellous. And so that's inside the compact bone. And it's very porous and full of tiny little holes. But most bones contain both types of bone. So if we first of all look at our long bones, so we've got the picture here of the long bone, and we've got the epiphysis, we've got the diaphysis, and again the epiphysis. And this is the areas, as you can see, at the top and or depending where the top and the bottom of the bone are, but the top and the bottom of the bone. And the diaphysis is the middle of the bone. So these lines here are where your bone actually grows from. So your bone doesn't grow from the middle, it grows from the platelets, the growth platelets, which are held in the just underneath the head of a long bone, and as both ends. Okay, so we've got down this side articular cartilage, which covers the end of the bone. We've got our epiphyseal line, which is our growth platelet lines. We've got spongy bone in the middle. In the middle of that, we've got the medullary cavity, and this is where we get all our nutrients, our blood vessels attached to our bones, and we get our nutrients. And this is called our nutrient foramen. In here, we've got our endosteum and periosteum. Which is what the endosteum is in the middle, and the periosteum is around the outside of the medullary cavity. So as you see here, we've got the diaphysis, which is the shaft, the epiphysis, which is the end of the bone, the epiphyseal plate, which is the disc of cartilage found in growing bones, and the metaphysis, which is the region where the diaphysis and the epiphysis meet. So a lot of cysts is going on there, but yes, so that's the makeup of a long bone. Continuing with a long bone, we've got our articular cartilage, which is haline, and you can see that that again is around the edge of the bone. And if we're looking at this bone here, which is a femur, we're looking at this part of the bone would be attached into the hip bone, and it would be a ball and socket joint. So the peristeum, its function is nutrition and repair, and it's also an attachment site for tendons and ligaments. Okay, the medullary cavity, which is fatty yellow marrow, and the endosteum is a layer of osteoblasts. We'll talk a little bit more about osteoblasts in a couple of slides. And then we've got our bone marrow. So red bone marrow is used to make blood cells. Yellow bone marrow consists mainly of fat cells. And at birth, nearly all marrow is red, but by the time we reach adulthood, red bone marrow is only restricted to the vertebrae, the ribs, the sternum, flat bones of the pelvis. And I know that when people do donate bone marrow donors, and also this one of the things that can be a big issue with people with leukemia. The bone marrow doesn't hold the blood cells correctly, particularly the white blood cells, and therefore causes risk of infection. So that's our long bone. Short bones, they're generally what we call cuboid or trapezoid shape, and they're usually found in your wrist or your ankle, as in this diagram here. We can show you with a nice little red picture there. They're in places where there's a lot of pressure. So if we look at, I'll move the pointer. If we look at the makeup here of the wrist, we can see that we've got lots of quite dense bones all made up as one, which would give us a greater ability to absorb shock and for movement of the hand. So spongy bone within the thin, so it's got a spongy bone within the compact cavity. And now if we look at the sesamoid bones, which is particularly our patella, and this particularly with the patella, it's developed within the and it's usually sesamoid bones are usually in areas again where there's high pressure, and your knees being the main supportive part of your body, with kneeling, jumping, all those sort of things are going to impact on your knee joint. Okay, so from short bones we go to flat bones. So flat bones, they're layers of spongy bone between compact bone. An example would be the cranial bones, so the bones in your head, your sternum, your scapula, your ribs, and they can be thin or flattened, but they tend to be slightly curved, usually slightly curved. And if we look at our little diagram here, we've got the sternum, and we've got a flat bone at the top of the sternum, which is keeps our ribs all attached to the middle of our chest. We've got our long bone here, we've got our sesamoid bone, our patella, and then we've got our smaller bones. This one's a medial cuneiform bone, intermediate and lateral. Our short bones, and then our irregular bones, which are in our vertebrae. A little bit closer looking at our vertebrae. So irregular bones, as you can see, all the way down our vertebrae. We can see here all the nerve endings that come out through there, and we can see that, not with this particular picture, but if we looked from, we would see some soft padding in between each disc of a collagen. Okay, so looking at bone growth and density. Okay, so this really is determined by all of these 5 functions, 5 things here. So our bone density can be hereditary, and the way that our bones grow can be hereditary. So if you've got a person with very low, parents with low bone density, there may be a chance that it would be passed on to you. The same as bone growth. If you've got any bone abnormalities your parents might have, then they might be passed on to you. Diet, if we don't have a proper diet, we know we need to have protein, calcium, phosphorus, all to enable our bones to grow properly, and we need a lot of vitamin D, and there's been a lot of talk in the last couple of years regarding being outside in the sun for at least half an hour every day, and having a diet full of nice green leafy vegetables. Years and years ago, people that developed developed things like knock knees or bow legs would be maybe to do with, one could be hereditary, but the other reason it could be would be a lack of vitamin D and calcium. So really what we're talking about is poor diet. Hormonal growth, growth hormones, they are again different in each person. The way that our endocrine system works is not going to be the same for every single person, so that can have a impact on the function of bone growth and bone density. Exercise has a huge effect on bone growth and density because it stimulates the blood flow to the bones and the joints, and especially weight-bearing exercise that is known to increase your bone density. And it's always, when we talk about menopausal women, we talk about increasing their bone density through menopause by doing weight-bearing exercise. So that's something to think about when you're prescribing exercise for middle-aged or perimenopausal or menopausal women. So bone modelling and homeostasis, so that's being continuously affected, and it's what continuously works all the time. So your bone is regenerating all of the time and rebuilding itself, and all those sort of things. So we need to make sure that we've got good levels of calcium for that, to enable that to happen. And the other thing that we need to do is to make sure that we get the pull of gravity on the muscles of the skeleton, because muscles only pull, they don't push. So by getting the pull of gravity on muscles, that will help with bone remodeling. Go on to now osteogenesis, which is bone formation. We have what we call osteoblasts, which are our bone forming cells. We have osteocytes, which are mature bone cells that maintain bone. And we have osteoclasts, which are bone cells that break down the bone for reabsorption. So the development of a bone is called osteogenesis or ossification. So you know that when we looked at the slide with the spongy bone, when bone formation is not working properly, or you get things like osteoporosis, then the holes in the honeycomb effect of the bones become bigger and bigger, which causes the bones to become not as dense and leads to a breakdown of bone density, which will then lead to easily fractured bones when you have an accident or as you get older. the same as the hormones that help with our bone density. We lose those as women during menopause, so therefore we need to make sure that we do weight-bearing exercise and also have a healthy diet. Okay, when we talk about hypertrophy of a bone, it's when the cells occur in response to physical exercise. So hypertrophy is when something grows. So by doing weight-bearing exercise, resistance exercise, we're going to get that pull against the bone, and the muscle against the bone, and that is going to put some stress placed on the bone, and that is going to increase the bone density in all of your skeletal bones. So hypertrophy means increase. Atrophy of the bone cells causes a loss of bone strength, mass and resistance. So what we don't want is what we want the whole time for people that we're writing exercise programs for is we want to increase the bone cells in response to exercise. We don't want them to start to to lose them. So as I say, calcium loss, again, that can be due to menopause, poor diet, certain types of illnesses or diseases. All of those things can cause atrophy of bone cells. I'm going to look at bone stability here. And when we talk about bone stability, we're talking about how your bone sits within the joint. Okay, so it really refers to the bone being able to stay in place under normal under normal circumstances. So the joints that we've got in our body, we've got ball and socket joints, we've got hinge joints, and our ball and socket joints tend to be our most what's the word I'm trying to say, unstable. They're the most unstable and easily, because they've got a huge range of movement, they're easily displaced. So we need to be very mindful about joint stability. Now, joint stability is also going to be determined on the muscle strength the strength of the muscles around the joint. So if we have say, if we take the shoulders, for instance, if we have a strong anterior deltoid and a weak posterior deltoid, which is so the front of the shoulder versus the back of the shoulder, a weak back of the shoulder and tight front of the shoulder is going to cause the shoulders to pull forward, and then that is going to cause the ball and socket joint in your shoulder to not be nice and smoothly working. It's going to be it's going to be weak in the joint. It's not going to run smoothly. It's going to start to wear off the articular cartilage around the edge of the top of the bone, and all these things will happen. So joint stability is really, really important for moving bones to make sure that we function properly. Joint stability is also impacted by gender and anatomical differences. So when we talk about anatomical differences, I'll give you an example of women have in their elbow joint, it actually has a different angle to a man's elbow joint, which means that when a woman throws a ball, she has a different articulating angle on her elbow joint, and that's why we're renowned for not playing ball sports as good as men. I'm not saying that there's women out there that don't play better ball sports than men. There is, but it's actually our gender impacts on and that actual angle, throwing angle of a ball. So exercise choice is also influenced. So if we need to stabilize joints. So we need to think about, if you're writing exercise programs for people, then you need to make sure that you are training both the prime mover and the antagonist muscle, so the opposing muscle groups. So if you're going to work the front of the shoulders, you've got to work the back of the shoulder to make sure that you stabilize the joint. Okay, so I think that's okay all on that slide. Let's have a look. So joint mobility is specific to the range of movement is defined as the distance or amount of movement a limb has in a specific direction. So again, if we go back to our ball and socket joints, our hinge joints and all of those types of things, how we are able to move through a range of movement is going to be determined by the joint, firstly. Secondly, it's going to be determined by whether one muscle group in that crosses that joint is more flexible, more stronger, more weaker, whatever. That is also going to change the range of movement in a specific joint. So factors that limit the range of movement was the shape of the articulating bone surfaces. So a hinge joint's not going to be able to move like a shoulder joint. The amount of muscle and fatty tissue that's around the joint. So if we think about maybe big people that go to the gym, and you see sort of bodybuilders with great big quadriceps. Okay, now their legs, so the quadricep muscles are really, really big. That is going to impede on their hip bones because they are not going to be able to have the same range of movement because they're not, you can't articulate in that way. The same as if people are have got a lot of adipose tissue, fatty tissue, then they're not going to be able to move in the same way as well. Another limiting factor is joint elasticity. So the actual, whether you, again, whether you've got tightness or weakness in the joint, the extensibility of the collagenous tissue and muscle. So that's really how much flexibility you've got. So extensibility is how much the muscle can stretch, a bit like extend and go back to normal. So if you're very inflexible, you don't do a lot of flexibility work, then that is going to impede on your range of motion. And also muscle and collagenous tissue temperature. So again, if we warm up, we're going to warm our joints. Our synovial fluid is going to become nice and viscous, and our joint will become a lot more able to move in the, you know, the range of movement will increase rather than cold muscles. Cold muscles don't are not able to move as freely as warm muscles. That's why flexibility work is only really recommended when you've got warm muscles. And it doesn't mean to say that you have to do a full-on warm-up, but even just getting out of the shower, having a shower, when you get out of the shower, all your muscles are going to be nice and warm, and you're going to be able to stretch a lot better. Okay, so moving on to joint structure and movement. So we've got 226 bones in the human skeleton, and the bones are all connected with 3 types of joints. Okay, we've got synovial joints, fibrous joints, and cartilaginous joints. So looking at the top one here, our synovial joints, which are the ones that as fitness professionals we are very, very interested in because they move quite freely, they allow movement, and so we need to know how those joints work really, really well, and we have to be aware of their range of movement, we have to be aware of what they can do and what they can't do. And as we can see here, we've got knee, hip and shoulder, which are particularly our ball and socket joints. Fibrous, these are immovable joints with bones held together by introsurus ligaments, which is like the if you look at the joints on the cranium or in the ankle, if you look at a skeleton, you'll see that like little ziggy-zaggy panels, and in the ziggy-zaggy panels, then that's what holds. They're the joints that hold everything together. The other one is the cartilaginous joint, and these are slightly movable joints with the bones formed within cartilage, and they fall into 2 categories. We've got synchondrosis, and that's formed with hyaline cartilage, and it's in the epiphyseal platelets at the end of a long bone in children. Now, synchondrosis is almost, it's really an immovable joint, which is it's band together with cartilage, hence it's a cartilaginous joint. We've got symphysis, which is where the articulating surface of the bone is covered with hyaline cartilage and it's fused on a pad of fibrocartilage for shock absorption. So if we look down here at the body part, we're looking at long bones, intervertebral bones, joints of the spine, and the pubic symphysis. So the pubic symphysis is where the bottom part of your pelvis is joined together with a cartilaginous substance or cartilage, and it's there basically for shock absorption. Also, it's there to soften when women give birth to babies. So you know, it's like everything in our body, there is a reason for it. The word symphysis means the process of growing together. There's a little bit of information there. Okay, so we're going to go on now to the axial skeleton, and the axial skeleton is the part of the skeleton that consists of the bones of the head, the trunk, and the vertebrae. So you see here we've got the skull, the auditory ossicles, the hyroid, the sternum, the ribs, the vertebrae, the sacrum, and the coccyx, which is the little bit on the bottom. So in a human skeleton, it consists of 80 bones in the axial skeleton, and this is composed of 6 parts. So again, we've got, as I said, skull bones, ossicles, meaning is of the middle ear, the hyroid bone, which is just under your chin here, and your rib cage, and your sternum, which holds your rib cage together, and your vertebral column. So you will need to know the difference between what is the axial skeleton and what is the appendicular. Now going on to the appendicular skeleton. The appendicular skeleton is divided into 6 major regions, and we can see here they're all covered nicely in a nice purple colour. So we've got the pectoral girdle, which is here, which is our clavicle. So we've got right and left clavicle, and our scapula. So at the front of the body here is the clavicle, and we can see that the clavicle is attached to the scapula. Okay. So right and left clavicle and 2 scapula. The arms and forearms, there are 6 bones. So you've got your right and left humerus, here and here. And then you've got your ulna and your radius. So this skeleton is standing in an anatomical position with its palms facing outwards. So you can see that the thumb is facing upwards. So you can then identify that the ulna is on the inside near the little finger and the radius is on the outside near the thumb, and that's a really good way of remembering that. And then we've got our pelvis, so there's 2 bones there, which is our right and left hip bone. On the posterior side of the skeleton, you can see where my little pointer is where the pubic symphysis is, the lump of cartilage in between which joins the pelvis together at the front. Okay, so again, just running down these, we've got our pectoral shoulder girdle, which includes our clavicle scapula, that is in our appendicular skeleton, and then our arms, our humerus, ulna, radius, carpals, metacarpals, phalanges, our pelvic girdle, hip bones, and then we've got our patella, our tibia, which is again our big toe side, and our fibia, which is our little toe side. Then we have our tarsals, metatarsals, and phalanges. And just for the colour key here, you can see that the axial skeleton is in the yellowy colour, and the appendicular skeleton is in the nice purple colour. Okay, so moving on to our ligaments, tendons and cartilage. So tendons and ligaments are made of a dense fibrous connective tissue. Okay, so they either connect bone to bone or muscle to bone. They have very poor vascularization, which means that they're very slow to heal, so they haven't got a lot of blood vessels going into ligaments, tendons, and cartilage, not like skeletal muscle or skeletal bone. So that's why if someone does a ligament, it takes a long time for it to heal. They don't heal very, very quickly. So they're collagen fibers, and they are clustered with what we call fibroblasts, so fiber-forming cells. Now, if we look here, we've got a knee joint here, and you can see the ligament there, which is attached onto the this is the knee joint. So we've got, oh no, yeah, that's right, it's the knee joint. So we've got the tibia and the fibula here. We've got the spine, and you can see the intervertebral discs, and that's made from fibrocartilage. And then we've got the one that everyone knows the most, Achilles tendon, and that is attached to the calcaneus and the medial gastrocnemius and lateral gastrocnemius, which is two of the heads of the gastrocnemius calf muscle. We've got little color coding here. So we've got, in the blue, we've got our hyaline cartilage. In the green, we've got our elastic cartilage. We can see here cartilages of the external ear and cartilage of our nose. And the red cartilage here is the fibrocartilage around our knee. So if we just go down here, we've got external ear, cartilage of the intervertebral discs, the meniscus, which is a pad-like cartilage in your knee. You've got medial and lateral, and then you've got the articular cartilage of the joint, which is again in red. So we've got a little bit of color coding there. Again, our pubic symphysis is pointed out here. That is in red, so it's fibrocartilage. And our costal cartilage here, which is what joins our rib cage to our sternum. And articular cartilage, again, in our shoulders, elbows, in our wrists, and in our feet. Okay, so moving on to tendons. So tendons attach muscle to bone. We can see here that we've got the bicep tendon. We've got the radius and ulna. And you can see that the belly of the muscle is up here, and the tendon is attached to the end of the muscle, and that attaches to the bone. So if you rip a tendon from the bone, okay, you can sort of have that operated on, and it will mend a lot better than ligaments, because ligaments attach bone to bone, and so they're attached to a more non-pliable substance. Ligaments are non-elastic, so once they're overstretched, then they make the joint weak because there's no support around a joint. So tendons attach muscle to bone. They're white, glistening, fibrous brands of tissue. Except at the point of the attachment, tendons are sheathed in a delicate fibroelastic connective tissue, which is strong and flexible. And it occurs in various lengths and thicknesses, obviously depending on the type of muscle and the muscle fibers and the area that is in the body. Okay, so ligaments. So ligaments join bone to bone, the white, shiny, flexible band of fibrous tissue, a little bit more stretchy than tendons, slightly elastic and composed of parallel collagenous bundles. Okay, it's covered with fibroelastic tissue that blends with surrounding connective tissue, And ligaments allow movement but limit abnormal or excessive motion of the bones. So when we talk about hyperextending a joint, the ligaments allow the joint to go into hyperextension, but constant hyperextension and constant repetitive movements will damage the ligaments surrounding a joint. If we look here, we've got a periosteum, which is the outside here, like a thin skin on the outside of the bone. Ligament here, attaching the bone to the bone. The joint cavity in here. Okay, the articular hyaline cartilage, which is on the end of bones. When that wears away, we then tend to get bone on bone, which is what we would call an arthritic bone. We've got a synovial membrane, which is in the green here. And these, the fibrous capsule and the synovial membrane, make up the articular capsule. Okay. So that's our ligaments. So types of synovial joints, the main ones that as a fitness instructor we look at are the vertebrae. We look at so that's an irregular bones, ball and socket joints, so the head of the humerus or the hip bone. And we look at hinge joints as in your elbow, which is your humerus and ulna. Other types of joints are gliding or plane. We've got hinge joints there, pivot, condyloid, saddle, ball and socket. So that's mainly all the joints that we have in our body. Okay, synovial joints are really, as I think I've said this, is important to the fitness instructor because we need to make sure that those joints are warmed up correctly to be able to go on to further exercise, to exercise without becoming injured. Okay, so we'll look a little bit deeper into our synovial joint here. And again, we've got our muscle, belly of the muscle being up here, and we've got the tendon, okay, which is being attached to the bone. We've got the synovial cavity here, and we've got the bursa. Now the bursa's got a huge job of protecting this knee joint. It's a sac filled with fluid, and when we get an injury to the bone, whether it be to the articular cartilage or the tendon or the ligament, what will happen is the bursa will swell and provide a cushioning around the joint to protect the joint from becoming further inflamed and damaged. So bursas do a huge job. Now, if a joint is constantly injured, what will happen is the bursa will become more inflamed and engorged, and we get a condition called bursitis. And that can become very uncomfortable because it's like the sac of fluid is huge and will then start to cause pain and impediment of movement on a joint. Okay, so we've got the joint capsule here and synovial lining, which is this purple colour here, and tendon, and then we've got the epiphysis, okay, which is the bottom of the bone here. Epiphyseal bone, which is what we're talking about, the bone platelets, growth platelets, sorry. And then in here we've got articular cartilage, which makes our joints sit nicely and smoothly and comfortably on top of each other. And then we've got our ligament down this side. So that's the way that the synovial joint is made up. Now, within the synovial cavity here, we have our synovial fluid, and when this joint becomes warm, that synovial fluid becomes very thick and viscous, and that is also there to aid smooth movement on the joint. Again, looking at cartilaginous joints are connected entirely by cartilage or fibrocartilage or hyaline cartilage, and cartilaginous joints allow more movement between bones, and hence that's why they're in our vertebrae. so that we can move from side to side, from backwards and forwards. This is a nice picture of nice, evenly distributed cartilage there. When we tend to get older or overuse or injuries, then this becomes a lot thinner, and again we may end up with the situation where we get bone rubbing on bone. We also may get situations where this bone actually moves out or inward from where it should be. So it could be like a bulging disc or a slipped disc, that type of thing. Okay, so that's our joints. We're going to go over again the bones of the skeleton. So you need to really learn these and know them really, really well. So that'll be the job for next Monday. There'll be a nice little quiz for those of you who have managed to watch this. Well, you need to watch this this presentation before next week. Okay, so we've got the skull or the cranial, and then we've got the facial portion of the skull. You've got the shoulder girdle here, which includes the clavicle and the scapula, as we said. Clavicle here, scapula here. Then we have the sternum, which is what the ribs are attached to via the cartilage. Okay, got our ribs. Then we've got our humerus, back and front, our ulna and radius, our metacarpals, our phalanges. So we've got our carpals, which are our wrist bones, our metacarpals, which are in between our wrist and the little digits on the end, which are called our phalanges. We've got our vertebrae column and our pelvic girdle, our hip bones. Okay, we've got our femur, our patella, our tibia, our fibia, our tarsals, our metatarsals, and our phalanges. So we need to learn all of those bones, where they are, what type of joints they're attached to, the range of movement of the joints that they are attached to, which way they can move in. Okay, moving on, we need to understand a little bit about the vertebrae column. So we've got what we call the atlas and the axis at the top, which is called C1 and C2. Okay, these are part of the cervical part of the spine. Okay, but it actually starts at C3. Okay, so C1, the atlas and the axis are right at the top under your skull, and then we start at C3 through to C7. So C3, cervical 3, cervical 7. So if you were to have a client that came in and on their medical health questionnaire they put damage to C4 and 5, then you would need to know what area that is. So you need to know that's in the neck. Okay, it's not in the lumbar part of the spine because it's cervical. It's in the cervical part of the spine. So very, very important that you know the areas of the spine. If we go on to the thoracic part, when we start with T1 here, which starts where the ribs are, and it goes through to T12. So we've got 7 in the cervical, 12 in the thoracic vertebrae. Okay, then we have 5 in the lumbar. Okay, so if someone was to come in and say, oh, well, I've got damage to L3 and 4, you'd go, okay, they've got damage in their lumbar part of their spine. What do I need to do about this? What do I need to check out? You don't want to be in a position where they say, well, where you ask your client, well, where's that? That's not very professional, and it's not where you want to be. Okay, so then we have S1, which is our sacrum, S1 to 5, which is our sacrum. This is fused. Okay, all of the rest of this is movable. Having said that, the thoracic part of the spine is the most immovable, and the most movable is the cervical part of the spine easily damaged and the lumbar part of the spine. So we've got the sacrum fused here, and then when we get to S5, then we've got our coccyx 1 through to 5, and they're the teeny little bones right at the bottom of your vertebrae. So very, very important you remember cervical 7, thoracic 12, lumbar 5, sacrum 5, coccyx 5. Okay, something for you to think about. Now we'll just go on to the thorax, so the thoracic part of the spine. So the thorax consists of 12 ribs, the sternum, and the thoracic vertebrae. So the first 7 ribs are known as the true ribs. So that's here, 1 to 7 down this side. And they have direct attachment to the sternum. Okay, and if we look here, we've got the jugular, what we call the jugular notch here, which is the reason it's called that is because the jugular vein passes through there. The clavicle notch there, so that attaches again. The clavicle attaches there. The manubrium here, and the sternal angle, the body, and the xiphoid process, and the sphixial. I think that I've said that wrong, but you don't really need to know those, but you need to know they all make up the sternum. What you do need to know is that is the sternum. Then we've got intercostal spaces here, so that's the gaps in between the ribs. And then we've got our costal cartilage, which is here, which is attaching the ribs to the sternum. Okay. When we look at the next 5 ribs, they're known as false ribs. So the first 3 false ribs have an indirect attachment to the sternum, whilst the last 2 have no attachment to the sternum at all. They're attached to the vertebrae. And these are called your floating ribs. So we've got 1 to 7, 8 to 12, but 11 and 12 are our floating ribs. Okay, so that's where we leave it for today. That's it's just over 45 minutes. Please make sure that you do listen to the whole of this before next week. So if you've just watched half of it, you won't be actually listening to me talking about this now, but I will put that in the email. Most imperative that you start to learn your skeleton, because next week we'll be moving on to the muscular system. So we're going to have a quiz on Monday night regarding the skeletal system, and you don't want to be one of the people that doesn't know what they're doing. Anyway, thanks for listening. I hope it's been informative. If there are any questions, please feel free to message me. Otherwise, I will see you on Monday in class. Thank you. Bye.